very much for finding the time to join me today. I'll be joined by Helen Brown, our Deputy Chief Executive, shortly. And my name is Louise Halfpenny and I'm the Director of Communications. And the point of today's session is just to give you a quick run through, and so you can see where we are with our progress so far to secure the money that we want to be able to provide the facilities that we want for our patients and for our staff. So this is a session on Zoom, and just to take you through the way that we're going to run the session. It is going to be recorded. I hope that's okay with everyone. Your microphones will be muted and cameras are off, which just helps us with bandwidth. And we ask that for this session, you use the chat function and you send it to Redevelopment team. And we would like to take questions at the end of the session, but please do fire them through as they come to you, send them in, and we will pick them up at the end of the session. You can look at a recording of this session if you want to see it twice. Tomorrow we're going to get it onto our YouTube channel and the link is there, and a copy of this presentation will be there, as well as the recorded filming of the session. So what we want to cover in the session is to take you through the preferred option for our 3 hospitals, the business case process, the timescales and our next steps, and the forthcoming engagement opportunities. And as I said, we will answer any questions that you have after the session, and we would like you to put them in the chat box, please. So just to remind you what our plans are for our 3 sites. We see it as having 3 networked hospitals. So each hospital does something a little different, but they all work together well, so complement each other and also fulfill some of the best practice that is coming to us from the NHS in this country, but also internationally. So for Hemel Hempstead Hospital, we see this as being a multi-specialty site, so a site where we will look after people with long-term conditions, and we will particularly focus on older people's care. We will have some new and upgraded diagnostics, including a DEXA scanner, which will be new to us, and we will continue to provide urgent care, routine, outpatient appointments, and also some maternity services. At St Albans City Council, and I'm sorry about these, we're just tinkering with the subtitles at the moment, because that they were coming through and that was a bit distracting, so we're just getting rid of those. So let me talk you through what we're going to be providing at St Albans. This will be a centre for planned surgery, and what we want to do is to broaden the range and the complexity of the surgery that we provide at St Albans. And it has been really helpful for us during the pandemic to have a separate surgical site, because we have been able to continue working through our elective waiting list. And indeed, there is a lot of NHS guidance that talks about the separation of 2 services. And we've been able to keep St Albans as what we call a clean site, or a green site. There's some different jargon around that. And that means that we have been carrying out additional screening on that site to enable it to be as COVID-free as possible. And that's been really important for us during the pandemic. The Watford General site will continue to be the site for emergency and specialist care. And we're really moving to a kind of emergency care that we call same-day emergency care. You know, we love an acronym in the NHS and a bit of jargon. So if you ever hear of something called SDEC, that's how we describe same-day emergency care. And really the point of that is to try and turn our patients around as quickly as possible so that they can move on to the right treatment that is appropriate for them. That may also mean being discharged or referred to another service. At Watford, we will also have some complex diagnostics and new buildings, which mean that we can group our services together more logically than they are at the moment. So intensive care would be nearer to surgery, for instance, or the women's and children's services all together. So really enabling us to rethink how our services are located. Also at Watford, and I should have said this for St Albans, there will be urgent care and routine outpatient services. So if the Zoom gods are with us, I'm going to show you an animation of how our Watford site would be. And it's important to point out that this is a rebuild and not a refurb. So I know sometimes people do worry about it being a patch up job, as it were. But actually, if you can see the current site, and then where this black is now, that is land adjacent to the current site. You can see the size of it, and this would be where the new buildings would be. So it's a really sizable development. You can see on it the car park is there, and that car park opens in April. So very substantial rebuild. So I'm going to hand over to Helen Brown, our Deputy Chief Executive, and she's going to talk to you about some of the process that we're going through. So over to you, Helen, if you've been able to sort out your the gremlins in the system there. I think we are having some issues at the moment, so I'm just going to take the next slide, if we can move that on.
Hi everyone, this is Helen. I have been unmuted. I'm still not allowed to be on camera, so Holly, if you can let me be on camera, that would be great. I'm really sorry, the Zoom technical gods have conspired against us today, but hopefully we're back on track. So I'm going to talk to you about the process from here. We're getting to the point where we've almost finalised our detailed cost benefit analysis of the options. I'm going to talk you through the options again, or recap them for you in a moment. And that cost benefit appraisal process is designed to identify the best overall value for money option. So the one that offers the best clinical benefits at best overall cost. We will be bringing a decision to our trust board, or a paper recommending preferred options to our trust board meeting at the end of May. The board will consider the options in the light of the latest timescales and the increased cost estimates, and I'm going to talk you through those as well shortly, and will receive a recommendation around a preferred option for all three of our hospital sites. There will be an opportunity for engagement ahead of this meeting. We will share papers in advance, and stakeholder views will be fed through to the board to inform its decision making. Once we have a confirmed preferred option, there's still quite a lot of work to do to complete the outline business case, including finalising designs and delivery plans. And once we've done that, we will then submit it to the new hospital programme and the Department of Health for approval. I think it's important to note that whilst we are working as hard as we can to progress the business case so that we can move forward with our ambition to deliver new and better buildings in the shortest time possible, being part of a national programme and needing to work really closely with the new hospital programme could result in delays to the process while we await approvals or funding decisions. There is a lot of work going on at a national level around all of the 48 hospitals in the programme. So we have to work at the pace set by the new hospital programme, but we are really keen to push this forward. It is so important for our patients, for our staff, and for the board. Next slide, please, Holly. Oh, I think I'm allowed back on camera now as well, so hopefully you can see me. So I'm just going to recap the options. I'm looking at this and it's not, we're not sharing the right version of the slides anymore, chaps, but never mind. So emergency and specialist care options at Watford are, as we said back in October 2022, we've defined 6 points on a spectrum from business as usual, right at the bottom end of the spectrum. So that's really just the very basic things we need to do to grow our capacity and for the future. Do minimum looks at the critical backlog and infrastructure, most essential infrastructure requirements. Option 3 is the option that was in the 2019 SOC, so it's a partial redevelopment of the site with new women's and children's facilities and critical care and theatres, but retains the current main clinical block, Princess Michael of Kent. Option 4 is an enhanced version where we still retain Princess Michael of Kent, but we invest in that building to bring it up to modern standards as close as possibly we can within the constraints of the building. Option 5 is the first option that replaces the main clinical block and is effectively nearly all new build for clinical, but retains the existing acute assessment unit as a clinical facility. And option 6 is where everything, all clinical services are accommodated in new build facilities, and the current acute assessment building is repurposed for non-clinical support accommodation. So that's the spectrum of 6 options for Watford General, or should I say for emergency and specialist care options, which will be on the Watford and Watford Riverwell site. In terms of St Albans and Hemel, each of those sites has 4 options that we've defined on a spectrum from business as usual through to do maximum, and they're just different points on that spectrum, with the enhanced option effectively being more than the absolute do minimum critical infrastructure, but not not the full scope of everything that we could potentially do to improve those sites. Next slide, please, Holly. So just saying a little bit about what happens after we've submitted the business case to the new hospital programme. Clearly, we will need to wait for their approval and the funding to proceed to the next stage. We're hoping that would happen in 2023, early 2023. But as I've already noted, that process is not in our control. Subsequent to that, a contractor partner will be appointed. That will be appointed through the new hospital programme, working with the trust, and we then develop the full business case, which is based on detailed cost proposals from the contractor that will build the new facilities and very detailed designs at that stage. We then submit the full business case, and when that's approved, effectively the final funding and the main building contract are all agreed. We all sign all the various documents, and we're ready to actually get going with the main build. In that then enables us to start the full construction of the new hospital facilities, and we expect on our current timeline to be able to start that build in 2024, with enabling and groundworks happening in ahead of that time scale, again assuming that we get approval for the funding to enable that to happen. So that was a slightly Watford focused view of the process. For St Albans and Hemel, there is the potential to bring the final full business case forward because they're smaller schemes, and we will be seeking to make progress on those 2 sites ahead of this timeline if we can. Next slide, please, Holly. So I'm handing back to Louise for these slides. Thank you, Louise.
Thank you. So this is just to give you a bit more detail on what our preferred option for Watford General will enable us to do and will provide. So new state-of-the-art buildings, as you've seen from the animation, we want all of our clinical services in the new building. We do expect to demolish and replace the main block, which we sometimes call PMOK, Princess Michael of Kent. The work that we're doing so far suggests that that would make better economic sense than trying to refurbish it. We do have the acute admissions unit on our site, which we would want to retain. It's in a pretty reasonable condition, and we would like to convert that for non-clinical use. We will keep some land on our existing site, and some of that will be for Mount Vernon Cancer Centre should that relocation go ahead, and there will also be some for future development. Of course, what we want to do with our new build is to move us closer to net zero compliance, which is a little difficult to do if you're building new, because that's not very carbon friendly, but obviously it's the thing that we want to do to provide the best facilities. And we will continue to maximise use of digital technology, so making sure that all of our rooms are digitally enabled so that conversations between clinicians and with patients can happen with the benefit of the latest technology. So really important for us. The next slide sets out what we will be doing at Hemel Hempstead. So we will refurbish the Verulam wing with all services co-located in this space. As you may be aware, it's quite a difficult site to navigate because it's kind of over two different buildings, and we will consolidate. We will increase the consultant presence on this site very much in the same way that we do at St Albans. So by making sure that we're providing services on one or two sites instead of stretching across three, we're able to use our staff time more effectively, and that means that we have sort of strength in numbers. This is very good for staff development and training, and it helps to avoid cancellations because there's better cross cover. So at Hemel there will be a new imaging department, new dermatology department for outpatient appointments and some procedures, education centre, and additional staff wellbeing spaces and multidisciplinary team facilities. So this is really, as I was referring to, able to look at patients' details using technology. So looking at screens on the very latest, which might be scan results coming from a scan that's been done on that same day. So really trying to make this very much a one-stop service, so that if you're coming to this site, you could expect to have several steps of your pathway, as we call it, addressed in one meeting. We want to establish new ways of working with our colleagues in primary care, and again on this site we will be mindful of working towards net zero carbon compliance. On the St Albans site, here we are, we will have a new endoscopy unit. The one at Hemel Hempstead is very cramped, and we also want to move it for reasons of it being a better and more appropriate site at St Albans because of the link with cancer surgery, which will be performed at St Albans City Hospital. We will have an additional increase in bowel cancer screening with scope for future growth as screening services do grow over the next few years. We will replace our theatre with 2 ultra clean modular theatres, so a real upgrade there, and increased recovery capacity because we expect to be increasing the complexity of the surgery that we provide. And again, improved staff and support spaces. We have overlooked spaces for staff, as have all hospitals, the age of our buildings, and we really have come to understand how important it is for staff to have decent spaces to get a break. We will have a new diagnostic centre at St Albans with an emphasis on rapid turnaround of results. and new organ function scan service, and hopefully a cancer information centre. So really bolting on some holistic services for patients as well, recognising that at this site patients might be receiving difficult news and we want to make sure that they are supported. So moving on to the next slide, and Helen, I'm handing back to you for this one.
Thank you, Louise. So this slide is a bit busier, but it does talk money, and I know that that is of interest to everyone. And it also recaps some of the history over time, because I thought that was important to set the costs in context. So just going back to 2017, when we did our first strategic outline case as part of this process, we identified our preferred way forward, which was redeveloping Watford for emergency and specialist care and St Albans for planned surgery. Back in 2017, there was a separate process looking at Hemel Hempstead Hospital that was led by the CCG. So the 2017 costs don't include any costs associated with the Hemel site. And at that stage, in 2017 prices, so without inflation, we estimated that we would need between 6 and 700 million pounds worth of investment, with the detail to be worked through at outline business case stage. And with added inflation, that would have taken us to 700 to 800 million of inflation. In 2019, we reviewed that business case, really following direction from NHS England to say that that amount of funding from the 2017 case was not going to be available, and that we needed to come back with plans that cost no more than 350 million pounds. So many of you have lived and breathed this process with us over the years, so we'll remember the 2019 case, and we really asked the question, well, what would we do within that maximum capital spend? And we agreed that the priority was emergency and specialist care services, and we recommended a partial redevelopment of Watford with some investment in St Albans and Hemel to address the key priority areas on those two sites. The costs then were 300 million to be spent on emergency care at Watford, 50 million at Hemel Hempstead and Satch. That's in 2019 prices, so not including inflation. With inflation, those costs increased to 410 million. And effectively, when the Prime Minister Boris Johnson announced that we would be part of what was then called the Health Infrastructure Programme, a figure of 400 million pounds was floated, let's say, and that was derived from the 2019 SOC. But we were always clear that that would not give us a full solution to our needs. It wouldn't deliver all of the benefits we would like to see for our patients, and the subsequent investment would be required. So we, subsequent to the announcement of the Health Infrastructure Programme, we spent some time in discussion with NHS England, asking effectively for permission to include options within our outline business case, which is the stage we're at now, that did include replacing the main clinical block, Princess Michael of Kent, and moved us away from the cap of 350 million, with a figure of 590 million, again in 2020 prices, so not including, well, in fact 2019 prices, not including inflation. And that was split with the 50 million retained for Hemel Hempstead and Satch, but additional funding considered for the Watford site to enable the replacement of PMOK. With inflation, those two services, with inflation, those two numbers come to 710 million, actually just over 710 million. All of these numbers that I've put in this slide are rounded, and they were all indicative numbers at that stage in the process. So this is just a kind of note that numbers do move as we work through the process, and I'm sure these will not be the final numbers, but they're the best numbers that were available at the time. So moving on to where we are now, our current estimates for our preferred option, which Louise has just talked through, which is for a effectively new build emergency care services on the Watford and Watford Riverwell site, and more significant enhancements to Hemel Hempstead and St Albans. Our estimated costs in today's prices, so without inflation, are 940 million at Watford and 140 million shared between Hemel Hempstead and St Albans Hospital. And with inflation, based on our current estimate of the delivery timeline, that is 1.1 billion at Watford and 160 million across Hemel Hempstead and St Albans. So they are big numbers, and nobody underestimates the fact that this is a very significant investment that we're asking the government to make in improving our facilities. But having done all of the detailed work and spent a lot of time looking at the Princess Michael of Kent building in particular, we really do believe that the only, very clearly the best solution is to replace that block. So we are making our case as strongly as we can for the investment that we believe we need. Now, all of this is obviously subject to board decision making, but this is the recommendation that the programme team will be making to the board, that we take these forward as our preferred options. If you could just bring up the next slide, Holly, I'm just going to give you some understanding of what it is that is driving the increase in costs. So hold in your head the regulator letter, which was 590 million, but 710 million including inflation, and then compare that to the numbers that we're at now. So that's just over a billion without inflation and 1.2 billion with inflation. So the range of factors that have resulted in that increase in cost. The first one is that we've reviewed the demand and capacity assumptions. We've looked at increasing capacity that's already come on stream over the last 2 years, and we have effectively increased the size of the hospital facilities on all 3 sites to meet our best estimate of future demand, taking into account all of the changes we want to make to the way that we deliver care and population growth, etc. There have also been a number of changes in the scope of the programme and the policy environment that we work in. So previous costings didn't include digital technology, and the costs that we've shared with you today do. So we have a full digital strategy, and there is a significant investment in the digital technology that will really help the hospital operate in the most efficient way possible in the future. We have also costed in upfront investment to make the new buildings as net zero carbon as possible. So environmental sustainability, absolutely key. The NHS has got a commitment to becoming net zero by 2040 and 2045 for the wider definition. We need to make sure that our new facilities support us to be as close to net zero as we can possibly be, but you do have to make an upfront investment in that to get the future payback from reduced energy costs and more efficient buildings. We're also incorporated some new clinical and building standards. I've put a couple of examples there. So we've increased the proportion of single rooms, that increases the total size of the hospital. And I put wider corridors, but the latest guidance asks for wider corridors to future-proof for things like robotic delivery. And again, that all adds to the cost. And then finally, this is a bit in the technical details, but in previous business cases, we had assumed that some elements of the redevelopment would be funded by private finance initiatives or lease solutions. So the car park, the energy centre and office accommodation had not been included in the capital costs because we had assumed a different way of financing that. The guidance is now clear that we're expected to include the cost of all of those components in the core costs for the scheme. And there are much fewer routes to non-capital based solutions, if I can put it like that. And then there's the impact of inflation. So since we started this work in 2017, it has taken longer than we'd hoped to get to this point, and our future projection of when we will be able to build has changed, and that just means that there is more building cost inflation that has to be built into the numbers. So that is why the numbers have moved. So I'm handing back to Louise now. We are on our last couple of slides. I promise we can see questions coming in thick and fast, so we'll get to some of those shortly.
Thank you, and thank you for the questions. Yes, they are coming in thick and fast. Many of them are the same, so we will try and group them. So I think, Helen, you've got quite a few money questions coming your way. So Helen will address those as soon as we are through these last couple of slides. So the next slide just gives you details of an information session that we have on the 10th of May. And at this session, we will be able to talk to you a bit more about the engagement that we will be running throughout May. And we call that an information session because that's kind of us giving you information. But of course, we do also value your engagement with us, particularly on services. So we would really like you to join us to talk about same-day emergency care, to talk about virtual healthcare, which is really expanding and we're having great success with. So we'd really like to talk to you about that and hear your views. And we are lining up a session to talk about design principles. And we have another session on travel and access at the end of May. So all of these sessions are advertised on our website and the address is below, and we have a page for meetings. So we will update this and we will use social media and Blueprint, our newsletter. So we will try to keep you informed about all opportunities that you have. But please do talk to us about services because your experience really does help. And let's remember that our plans really are based around services. So that is what drives us, getting the right experience, the best experience for our patients. And we really do want to talk to you about models of care. The next slide gives you a note about our, a note about, it was going to give you some information about Blueprint, which is our newsletter, but we have details of how to sign up for that on our website. And then, as you can see, we're over to questions. So before handing to Helen for some of the questions about the finances, I had a couple that I was just going to pick up. And one of those was about the acute admissions unit and what we're going to use that for. And I don't think we have all the details of this worked out, but it is going to be for non-clinical space. So as I said, it's in quite good condition at the moment, and we will be looking at what it can be used for non-clinical space. So sorry not to give you a more definite answer, but we will be unveiling more detailed plans as we go through this process. You asked about how long the engagement will be in May, and we want to keep that fairly tight because obviously we've got a huge programme of work, so we anticipate that being during May and not going beyond the end of May, but we will give you more details on that either at our board meeting in early May or via the information session on the 10th of May. And there was a question there from Graham about the nature of the question asking and why you're doing it through chat. And I know some people don't like that, but also some people do. It's quite hard to get the balance right. And so apologies if you don't feel that it is right for you. But I guess if we were in a public meeting, not everybody would get to know everybody else's question before, but for us it's really useful in grouping the questions. So several of you have asked similar questions, and it just means we can put them all together, and Helen will go through a range of those questions in one go, as it were. So it's not intended to stifle debate. We are asking the questions that are sent to us. And a couple of others on transport. So Helen's going to talk a little bit about work we're doing to improve accessibility, and we know that that is an issue for you. So we are working on that, and we've had some recent success. So I'm just going to speak a little bit about one tiny part of our travel and transport services that are around in West Herts, and particularly in the Watford area. We have a new or a bookable bus service called Arriva Click, and I know there was a question about South Oxley, and I think that service might reach out to there, but I will find out and get back to you, Jenny, about that. It's a bookable minibus service, and it's fairly reasonable, about £2.20 off peak and £3.30 in peak, and it can drop right inside the hospital. So this week we succeeded in getting a stop right inside the hospital. So we did hear from a travel and access group earlier this year that it was the final mile that was the worry point for so many people. You could get into Watford, but how do you get to the hospital? So we hope that that has solved that issue for some people. I know it's not going to solve the issue for everyone, and we will look at similar transport provision in St Albans and Hemel Hempstead. So it's very much a work in progress. I'm going to hand over to Helen, who's going to start with some of the finance questions and also address cancer treatment at St Albans. Over to you, Helen.
Thanks, Louise. The trick is that I don't know what the finance questions are, so you might have to feed some of them through. But if I go first then to cancer services at St Albans, and this is a question that I have been asked before, particularly to say, well, what's the difference between that and with the potential for Mount Vernon to relocate onto the Watford site? How does it all work? Now, the truth is that, you know, all of our specialties get involved in cancer treatments to different degrees, and the pathways start in primary care with GPs identifying a risk of cancer. You come through a diagnostic phase, a review phase, and then treatment planning. And what we're saying about St Albans is that will be our main site where we focus most of our diagnostics and treatment planning for cancer, and most of our cancer surgery that is undertaken by the Trust for patients that are suitable for receiving treatment on the St Albans site will happen at St Albans. Clearly, patients needing more specialist care will still access that, whether that's at Watford or in other organisations, and patients who need chemotherapy or radiotherapy will get that through the service at Mount Vernon. But there will be a real focus on cancer diagnostics and treatment planning and cancer surgery on the St Albans site, but some elements of cancer care will happen actually in every hospital, whether that's our 3 hospitals or all of the neighbouring hospitals. I'm happy to try and answer if there are more detailed questions on cancer, or we can pick that up again as a stakeholder session around cancer services in due course. So moving on to the money, Louise, do you want to give me the gist of the questions that are coming in?
Yes, absolutely. So there's one in particular about the 400 million and, you know, how can we be looking at something that's over £1 billion when not so long ago, well, it was actually a couple of years ago now, we were told to look at a figure that was in line with our turnover. So it's really, is that against government guidance to be looking at that kind of figure, sort of, you know, what's changed for us in the regulator landscape for us to be able to look at these new figures?
Yeah, thank you, Louise. So it's a very fair question. Back in 2019, the very strong view from NHS England was that they were not going to be able to access as much capital as would be needed to do what we're asking to do now. Private finance initiative had effectively come to an end. The government had announced the the end of private finance effectively into the NHS, but no new funding routes had at that time been announced. So to be fair, with a slightly heavy heart back in 2019, we said, okay, well, let's look at what we could do for the amount of funding that NHS England was saying they thought they would, potentially be able to identify. But we were always clear that it would only get part of the solution, that there is no solution that meets all of the case for change that could be delivered within that kind of number. Shortly, just literally within months of us having completed the 2019 strategic outline case, there was a change in Prime Minister, and the then new Prime Minister, Boris Johnson, has got a track record and interest, I think it would be fair to say, in infrastructure investment. And there was an announcement that there would be some increased investment into the NHS to support improvements to hospital buildings, and in fact non-hospital buildings in the NHS. So the policy context began to change when with the change in leadership at government level. I think it's also fair to say, so that's one part of it. The part of the last 18 months, or a significant part of the last 18 months, has been spent debating still between all of the hospitals in the Pathfinder group of the new hospital programme. So that's us and 7 other hospitals, 5 of which were announced back at the same time of us, and 2 have been added subsequently, to say, what does it really cost to deliver new hospital facilities, and what is the scale of the case for change and the scope of the investment. So we are not alone in being in this position. All of the hospitals in that cohort have got a similar challenge, in that the funding envelope that was announced back in 2019 isn't sufficient to meet their preferred options or the full case for change. There is some variation in that, but largely our understanding is that all of the pathfinders are asking for a significant increase in the funding in order to be able to deliver their preferred options. Now, there is no guarantee. There absolutely is no guarantee that we'll get this level of funding, but we felt that it was incumbent on us to set out what we think we really need and what will get the best solution, and make that really clear, and to really make the case as strongly as we can. And again, I'm aware that other hospitals in the programme are doing similar. Clearly, the government has some really difficult financial challenges that it's facing on the back of the last few years, the COVID pandemic, the current issues in Ukraine, the squeeze on cost of living. It is a really tricky financial context that we're operating in. So I can't hand on heart tell you that I think we definitely will get the money that we're asking for, but I can tell you that this would give us the best solution longer term, that the economic evaluation does demonstrate that it makes more sense. Now, to be fair, many of you have been saying that over the last years, that it doesn't make sense to invest in refurbishing old buildings that are not fit for purpose and are not going to be fit for purpose. And we are really just making that case as strongly as we can. If ultimately the funding is not forthcoming, then we've got all of the options detailed, and we will need to sit down with the regulators, the Department of Health and the Treasury, and say, okay, these are the spectrum of options. What do we think is affordable to deliver, and what are the implications of not moving forward with our preferred option? I noticed that there was a question about affordability of that investment, and that again is a fair comment and a fair challenge, because as I've said in the past, this is not free money. It's not like winning the lottery. It's more like taking out a mortgage. So we do need to be confident that we can afford to run, that we can afford the cost of that investment. That again is part of the detailed economic appraisal and the finance case, and we will be setting this out in more detail in the papers that we share ahead of our May board, and for those of you with a real appetite to understand the numbers, there'll be significant level of information and detail included. But effectively, we have worked to identify all of the potential financial benefits from this investment, more efficient buildings, more efficient co-location of services, investment in digital to release workforce costs, and we've looked in really close detail, and the economic appraisal, the financial appraisal as it currently stands, says that our financial position would improve off the back of this investment compared to the business as usual scenario. But that's not to underestimate that does set us a real challenge to deliver improvements to the efficiency of the way we deliver care, but that will be significantly enabled by the new investment. There is some discussion about some changes to the financial regime. I think there is a recognition that the current capital charge regime does place a burden on individual organisations who need significant investment. So there is potential that may change and slightly reduce the challenge for us, but that's not the basis on which we've done the business case at this stage. We've done it based on the current regime. So are there other questions on finance that I really ought to pick up? I think we've covered, yes, that's a big number. How realistic is it? Is it affordable? Are there any other questions, Louise?
Well, just about, I mean, maybe just to confirm that the need to link it with projected turnover is either broken or not as strong as it once was.
So absolutely, the 2019 steer was what we called a 1-to-1 ratio between turnover, so the total income that the trust, well, income and expenditure for the trust in a year, was then translated into a capital figure. That was a 1-to-1 ratio. That effectively, yes, we are moving away from that ratio. We have moved away from that ratio, and although our turnover has increased in the last period and will continue to increase, we're going to be well above a 1-to-1 ratio. But again, we are not alone with that. And the 1-to-1 ratio was really a rule of thumb that really allowed trust to estimate back in the 2019 context what capital NHS England thought they would be able to secure. But it's not a hard rule. It's not in the Green Book, for example. That doesn't exist. What you do have to demonstrate is how you will afford the investment, and that's what our business case will cover in detail. So shall we move on from money?
Yes, thank you. I just wanted to address a question that came in about the state of buildings and how it has impacted on experience of our patients. Absolutely, we do understand that, and we're not happy about it. It's not what we would want. We know that some of our buildings do provide very, very poor environment for patients and also for our staff. And the questioner asked if we alert the Department of Health to the impact this has on patients, and we absolutely do. We think we have totally succeeded in making a case for change. And that's how it is that we are in this cohort 3, so called the Pathfinders part of the new hospital programme. So we are in a priority group, and we have been saying for some time how bad our buildings are. We've had visits from the new hospital programme, so they've seen the worst and also the best. They've seen some of our new areas, so they can see what we can do where we have investment. So we do raise this as an issue, and we do believe that we've been successful in that. I wondered, Helen, if you could just talk about some of the other wider transport issues that we are addressing, and some of the cooperation that we are having with local authorities.
Yes, so access to the hospitals is a really important issue. It's really important right here and now, regardless of what our future plans are. So we have been working to look at opportunities to improve access to the hospitals. the current focus is quite significantly on the new car park at Watford, because that will open in April. That will significantly improve car parking and access for people who drive at the Watford site. We do know, though, that not everybody drives, and car parking is only part of the picture. So we have been working closely with Hertfordshire County Council, who actually have the overall lead for infrastructure and travel in Hertfordshire, but also with Watford Borough Council, Dacorum and St Albans District Councils, to really sit down together and say, what are all of the different things we could consider? And it also links to our green plan. So we have recently published a green plan that was approved by the board in February, that sets out our ambition to be one of the greenest acute hospital providers in the country. We need to do a lot of work to get there, but looking at travel is part of that. So new ways to deliver care that reduce the requirement to come to hospital, whether that's virtual care or just more streamlined care pathways, and we've talked to you about that before. We've just done an analysis over the last 2 years as we've been implementing new models, not as a result of COVID, but kind of accelerated by COVID. We've delivered 45,000 outpatient appointments in different ways, either by advice back to GPs or through virtual appointments, or just streamlining and not bringing people in as often. And that has translated into a huge saving in time for our patients, in cost for our patients, and also in carbon emitted. So we're continuing to look at all of those things. And discussions about public transport are a bit more complex and take a bit longer to work through. Louise has flagged that Arriva Click is a great option for people who live in Watford for accessing the hospital, and hopefully that takes some pressure off the car park. There are longer term plans to continue to improve walking, cycling, public transport options in Watford that are set out in their travel plan. St Albans and Hemel are both also working on plans and recognise the importance of green travel options, but also just improving access in those towns and between the towns. So I can't promise that some of those changes will come through quickly, but I can promise that we're putting a lot of time and effort into this. And just finally on that note, we are keen, we've been making some links with volunteer driving services, and would like to develop a stronger partnership with community and voluntary groups that will bring people to hospital, because for some of our patients that really is probably the best option, and we want to make that easier for both the volunteer drivers but also more widely available. Again, it will take some time, but the commitment I'm giving and the assurance I'm giving is that we are absolutely working to find ways to improve accessibility to the 3 hospostals.
Thank you, Helen.
Money, I can see caps locks on this from on money and the split between Hemel and St Albans. I mean, it's a roughly equal split, with slightly more at St Albans and slightly less at Hemel, probably about a 60-40 split. I haven't got the exact numbers in front of me, and it does depend on the final recommendation from the option appraisal about exactly where we land on the detail of the work on the 2 sites. But as I said, probably a 40-60 split is about right for where we will be on Hemel and St Albans.
Can I ask you, Helen, about, sorry, I'm wondering, as we're short of time, if we had a question in about the cost of a new hospital on a new build, with a suggestion that it would be half the price of the figure that we've taken people through this afternoon. I wondered if you had a comment on that.
Yes, there's no evidence that building a new hospital on a new site would be cheaper. In fact, we went round this loop in 2019 because the campaign group did challenge our costings and suggested that it would be significantly cheaper. There was an independent review commissioned by NHS England that looked at that issue and supported the trust costings and gave an indicative cost for a new hospital on a new site. Effectively, the thing that drives the cost of a hospital is how big it is. So unless we think it will be magically much smaller on a new site, and there's no reason to believe that, we've got to plan for the activity that we need to plan for, and the building standards are very clear about size and scale to meet demand. So let's assume for now that you're talking about exact like for like provision between building it at Watford or building it on a new site. The actual build cost is largely the same. There is a small additional cost, and I know that the experts in the room today from the campaign groups will say there's a slight cost to tall buildings. So yes, there's a small cost to tall buildings that's been factored into our costings for Watford, but equally there are a set of costs on a new hospital site that would counterbalance that are not there for redeveloping on our existing site. So any improvements to road infrastructure that would be required, and that can be quite significant, the cost of putting in all of the utilities needed for a hospital, the oxygen supply, the gas and electricity, they're all difficult to quantify on a new site without doing really detailed work. But effectively, there's no significant difference between building the cost of building on the Watford Riverwell site to a different site. And I've said it before and I will say it again, and I'm sure I'll say it again some more over coming months. The reason we didn't include a new site option in our shortlist was not because of cost, it was because of deliverability and the time that it would take to do that. We're not in a position to do a detailed cost comparison because we haven't got an identified new site and we haven't done the detailed work that would be required to do the detailed cost analysis. But it wasn't about cost, it is about deliverability and timeline.
Thank you. That takes us to 1 o'clock. I'm sure you've all got more questions, and I'm sorry that we didn't get through all of them on this session. There will be other opportunities. Please, if you don't yet get Blueprint, we do produce that every month, so it's a useful way of keeping updated. Visit our website, find out about the meetings. There will be a copy of this presentation on there and a recording of this. I'm sorry we had a few technical problems at the beginning. You won't be surprised to hear that one of the team members who was going to join us today to help is unwell with COVID. We're a bit short-staffed and trying at the last minute to make it all run smoothly. We didn't succeed as we might have liked to have done on this occasion, but hopefully you are patient with us and you understand. We will be seeing you again, I am sure. Thank you, Helen, and thank you everyone for joining us. Bye-bye.